All right, good morning. It's a pleasure to be back and not so early in the morning. Any questions about anything from yesterday? Sure, because everything from here on out is based on yesterday. Okay, let's go.
Oh wait, I have a question. So I know we have like a preferred approach for asthma and alternative. Will we ever use the alternative instead of the preferred?
Those are going to be Those are going to be based on things like insurance, preference, allergies, anything that would warrant you not to give the preferred. So think very first line, when would you give second line treatment? Those are all that type of rationale. But very rare, literally just insurance, allergies, patient preference. Yeah. Okay. Any other questions?
So for the severity, we look at 3 months of therapy.
3 months of controller therapy prior to that moment that you're trying to classify severities.
Okay.
So they have not been on controller therapy at all, or they just started it last week, do not classify the severity. Okay. All right, so getting into inhaled corticosteroids, I would highly recommend to know if I gave you the brand generic. All right, so where are we going to see these ICSs everywhere? I just want to kind of preface it with that. As we talked about yesterday, we're not generally going to see an ICS by itself, but we do need to understand everything else about the ICS, as it's going to be a combination with something else later on. Okay, so this is just here so that you can kind of see where which steps in therapy would be used in ICS, whether it's combo or by itself. And as you see, step 1, 2, 3, and 4.
Alright, so we're transitioning into the pharmacology of anti-inflammatory drugs. We discussed this yesterday briefly, the broad classification, anti-inflammation, inflammatory drugs and bronchodilators to basically help patients with asthma. We're diving deep into understanding the mechanism. There's a lot going on here, so let me just, what's it? Did anyone say anything? So there's a lot going on this slide, but what you just have to take home from this particular slide is how these anti-inflammatory drugs are going to help with inflammation. One of the things they really do well is anti-inflammation. From the same class, they're anti-inflammatory, so they basically do anti-inflammation. So if you just think about that for a bit, you will understand that inflammation is all because of inflammatory mediators. They down-regulate those inflammatory mediators. Again, inflammation is carried by what? The inflammatory mediators like COX, IL-1s, IL-2s, interferons, prostaglandin, leukotrienes. We discussed all those inflammatory mediators. They decrease all the pro-inflammatory cytokines. And the other thing they also do is they upregulate a beta-2 receptor chain. We haven't got so far, but I'm just telling you that most of the times ICS is combined with a SABA or a LABA only because, as Dr. Macaulay has mentioned yesterday, that if you keep using SABA for a long time, the receptors shy away. They come down on the surface. For the receptors to come, if they come down below the surface, the drug doesn't bind to it. There is no effect. So when we use with an ICS, it has an ability to upregulate those down-regulated receptors. So what happens now? So you're getting more bang for your buck. You're basically having upregulation of beta receptors and also down-regulating those pro-inflammatory cytokines, which are causing excess inflammation and causing that havoc of structural changes, which we have seen in people with asthma. So on this slide, on this diagram, basically what's happening here is during an inflammatory insult, interleukins and this kind of like this NF-kappa B mechanism where these inflammatory cytokines, they bind to a receptor because for any interleukins or TNF or platelet activating factor, they have to basically go and express at the level of the gene. You cannot just like have an inflammatory cytokine just form here and there. It has to basically be formed at the level of a gene. When you talk about genes, you talk about receptors called as nuclear receptors. So these inflammatory cytokines basically come and you do a dimerization of this receptor over here, and that gets translocated into your nucleus. And this nucleus basically has two mechanisms here. They causes increase in the gene transcription. Okay, so there is CBP and these activators and cofactors. This is all good information. I'm not going to test you on that, so please don't lose your sleep. What I have to do really is explain you on what's happening on your left side and how corticosteroids are going to help towards your right side. So all these inflammatory cytokines are going to increase the genetic transcription of those inflammatory cytokines as such. Corticosteroids, the receptor target for corticosteroids is important. The target for corticosteroids is glucocorticoid receptor, also known as GR. So corticosteroid, if you see, this is basically your lipid membrane, doesn't have the receptor there. Where is the receptor present? It's present below so it is basically a nuclear hormone receptor. It's present below the cytoplasm surface. So this corticosteroid binds to the receptor. As soon as corticosteroid binds to the receptor, it primes the receptor. They together form a dimer and translocate to the nucleus. And then when they are at the nucleus, they basically are going to inhibit all what is happening here. They are going to have an ability to inhibit the acetylation process, which causes increased gene transcription, finally reducing gene repression. Okay, this step is basically increasing the gene expression of cytokines. This step is decreasing the gene expression of cytokines. That's how corticosteroids. All right, so that's kind of like at the genetic level, the mechanism. As we move forward, we have discussed about this already. The eosinophils, again, all of these mechanisms fall in place with respect to what these anti-inflammatory drugs really do. They reduce the eosinophil recruitment. So which IL are talking about here for eosinophils? IL-5, so decrease eosinophil survival, reduce inflammation, reduce pulmonary hyperresponsiveness. What is pulmonary hyperresponsiveness? Hyperresponsiveness. We haven't discussed any interleukins for that. There's nothing for hyperresponsiveness. But what we have also discussed is asthma is an hyperimmune response. That's where this is coming from. So they're basically trying to reduce your hyperimmune response to any kind of allergen out there. So you basically reduce that and you revert the desensitization, which we already discussed. So this is a big problem with beta 2 or SABAs out there. So we can basically reduce that. How? By upregulation of those beta 2 receptors. This is a pictorial way of looking at it. So spend a lot of time. Moving forward, we have the structure of a kind of glucocorticoid. Over here, we have this medicinal chemistry SAR point. What it basically says is that the presence of ester in this molecule helps for a stronger bond with the glucocorticoid receptor. Okay, it's highly rated in the respiratory tissue. That way, it has more pronounced and prolonged effect in people with asthma. Okay, so the only thing which you have to remember is this ester group over here. Any of the glucocorticoids out there, dexamethasone, fluticasone, and there's so many out there, they all have to have this particular metabolite, like this particular moiety, which is your ester. There are two reasons for that. One, it helps for strong bonding with GR, which is basically the target, because if you take a fluticasone, it has to still go and bind to a receptor. The drug by itself cannot be effective without binding to a receptor. So it increases the bonding capacity, also the retention. That way, there is more bang for the buck. Okay, so this is one SCR you have to remember.
Let's go back.
All right.
Oh, anyway.
Okay, we'll just go over the knowledge checks. You have the answers here. But, which of the following genetic transcriptions will be reduced by ICS? From all the things you have learned so far, is COX an anti-inflammatory mediator? Yes. IL-4, 5, leukotriene, histamine. What about beta 2 receptor? Except beta 2 receptor, everyone can be reduced. You throw any inflammatory mediators over there. Whether you have seen it, at least heard it once, like platelet activating factor, proteases, anything which has to do with inflammation, corticosteroid doesn't distinguish, it goes and shuts down all the inflammatory mediators. That's kind of like a blanket term we can use for any of those corticosteroids or ICS. Moving forward, patient is prescribed fluticasone fluoride. What special feature contributes its prolonged effect in asthma management? So we have discussed this, the ester bond. A clinician wants to reduce eosinophilic inflammation in a moderate asthmatic patient. Which drug class will be most effective to reduce eosinophil recruitment and survival? So let's go one by one. Does beta 2 has to do anything with eosinophils? So what does beta 2 is used for? It's a sympathomimetic for bronchodilation. Anticholinergics again. Bronchodilation again. Leukotriene inhibitors. It's a non-biologic but an anti-inflammatory. But does it have anything to do with your eosinophils? All right. So then the only thing which is left over would be your ICS because it doesn't distinguish anything. But if there was an IL-5 inhibitor, then what is the preferred choice? IL-5. You're more selective. Okay. Right now we don't have IL-5 inhibitors, so ICS will be the go-to drug. A patient on chronic ICS therapy develops reduced responsiveness to beta 2 agonists. Which ICS-related mechanisms might help reverse this? So we have talked about the problem with beta 2 agonists, that patients on long-term therapy with beta 2 has reduced responsiveness. Which ICS-related mechanism can reverse this? So we have decreasing transcription. By reducing the transcription or formation of beta 2, we are preventing the drug not to bind to the receptor. Is it helping or reversing it? Is it making it worse for the patient or is it helping the patient? It's helping the patient by downregulating your beta 2 receptor? No. So that's what it's asking. Decreasing the transcription means you're downregulating. So you're basically still keeping the receptor downregulated, which we don't want. We want the receptor to come to the surface. So that's not going to help. So the opposite of that is enhancing the transcription, which can help. Okay. So you have to understand the terminology. Transcription is basically like formation. Okay. So just don't get confused with that. There's nothing to do with M1, right? As long as you understand the target for SABA, the target is beta 2. So then you will have all the other distractors like M1, IL-5, you don't have to care. So you just have to have your foundation strong so that all those cues will always be there for you to basically misguide. You just, if you know the answer in 1 second, and then you move on. Got it? All right, so this is the same thing which I put it on a different slide. So we're looking at the same answer. So.
All right, so these are the meds that you'll need to know. The ones that, to make it easy, if you memorize the ones that are once daily, everything else is right. Yes. Back to Michael's question earlier, though, how often are people going to get ICS by itself? Not that often. If you're stressed about what to study, I probably. All right, so when we get into when we get into classifying the dose, when we talked about low dose, medium dose, high dose, we were asking how do we know if it's low dose? How do we know if it's medium dose? This is how we know. You have to memorize the table, but you do not. You have to know how to read it. Yes, you do. This is why you probably should move it up on the list. Because you need to know, if I tell you about Vesco, you need to know which of these generics should I even be looking at. Does that make sense? Okay. So this will have pediatric and adults on it, so you'll see age 12 and up, age 6 to 11 for each drug. So make sure that when you're reading this, it will be provided to you as part of your scrap paper. When you're reading this, make sure you're reading the right row for the correct generic. Right? So we're just going to jump right in. 34-year-old is currently taking Alvesco 160 micrograms, 1 puff twice daily. What strength ICS is she taking? So what generic is Alvesco? And what's the total daily dose? So that math is going to be real important. We will have a calculator on exams often, not the calculator. Okay? So 160 micrograms, 1 puff twice daily. with confidence. 120 times 2 puffs a day is 320 micrograms a day. Okay? If we go back to cyclosamide, 12 and up, is at 320. So what dose is that? Medium. Good. Does everybody see why that's medium? Does that make sense? All right, so we'll do it again. 15-year-old male is currently taking Flovent, HFA, 44 micrograms, 2 puffs twice a day. It's the generic of Flovent. Which one? Which one? 13.8. Okay, and how many micrograms a day? 2 puffs twice a day. 176, so very good. So 44 micrograms, they're taking 4 puffs a day total. Okay, remember this dosing here is based on the total daily dose in micrograms per day. Everything you need is on this chart except for the branding. But everything is on there. Micrograms per day. So you need to calculate the total micrograms per day. It's 2 puffs twice a day, it's 1 puff twice a day, 3 puffs 4 times a day. Whatever it is, total puffs per day. Okay? So 44 equals 176 total. So what strength is that? So, okay. So cough, wink, this will be a question. And it won't be either. Okay. All right, so some common side effects of ICS, which should all be reviewed from Care Lab last semester. Oral candidiasis, which is thrush. What does that look like?
White tongue.
A white tongue. Do you think I'm going to put the red thrush on the test? Yes. No. Do you think that a patient is going to say, "Oh, I'm having thrush"? No. So I'm not going to put the buzzword on the test because that's not how you're going to see it. Okay, you need to know what thrush looks like, how it presents. If the patient is complaining of X, Y, and Z, you need to be able to say, "Oh, that could be from whatever drugs." Okay. Can also cause cough, pharyngitis, epistaxis. What is that? Nosebleed. Good. And headache. I will tell you that the cough and the pharyngitis are usually due to poor technique, which is why that counseling is so important to make sure that they're taking it correctly. You bypass the thrush, the cough, and the pharyngitis with proper technique. Okay? Some serious but less common side effects of hypersensitivity reaction we're going to see all the time, so I'm going to skip it on. Glaucoma, pneumonia, cataracts, and osteoporosis. That osteoporosis is also due to that high dose, improper technique, also being on oral steroids, just a synergistic effect from that. Okay? Make sure that they're rinsing their mouth out after every use. So when you're counseling a patient about how you use it, if they are not mentioning it, you maybe want to ask, what are you doing after you use your inhaler? Oh, I go about my day. That might be why you have thrush. Okay? Any ICS containing drugs, so even if they're on a combo that has an ICS in it, that counseling point is the same. All right, so there are some myths about the side effects you've probably heard with steroids in general. One, question about growth suppression in children. Is that really going to happen? Like, oh, I don't want my kid to be on an ICS because I want to be sure they love to play basketball. It sounds funny in class, but then you get into practice and they really do have that very symptom. However, a lot of studies have shown that children who are treated with ICS usually achieve normal adult height by the time they become adults. Okay? So this is how we empathetically soothe that concern while still counseling them to the right medication. By the time they become an adult, they are most likely going to reach their normal adult height. Okay? Does it decrease bone mineral density? So low to moderate doses are not associated with that decrease in bone mineral density for children. However, long-term use can result in that, which would result in an increased risk of fractures in adults, which is why we want to use that low-dose ICS as often as possible. So is it going to cause a kid to be short as an adult? No. Is it going to cause someone to maybe have osteoporosis as an adult? Maybe. Okay. So lower the dose as often as possible while still maintaining control. I'd rather you have osteoporosis as an adult than to die faster. That's how I think about it. That's what I tell parents when they deal with it. But we can treat osteoporosis. We can't relieve that. Okay? Okay. All right, so some safety concerns. Along with those side effects, we'll be monitoring for. So again, everything you've already talked about in care lab. After this exam, you learn in care lab lessons. So we want to make sure that check on the frequency of how often they're using that reliever. Whatever reliever they have, even if it's their March, maintenance and reliever period. So if they're using the same controller for maintenance and reliever, you still want to know how often are you using it to relieve your symptoms. Because if it's too often, you may need to increase your maintenance dose instead. Figure out how adherent are they to their maintenance dose. So how often in a week do you typically forget? Not do you ever forget, you're going to say no. How often in the past week would you say that I forgot? Okay? Check on their peak at start rate flow, PEF. So it's kind of like spirometry, but it's not. It's more of an at-home version of that, but it's still a PFT, pulmonary function test. Just out of office. And then oral health. Why are we checking on their oral health? Thrush, excellent. Precautions. We want to avoid high doses in patients who already have low bone mineral density. Just talked about how it can potentially make it worse. So we want to not give them something that's going to make it worse faster. And then we want to avoid 3A4 inhibitors. Contraindications, that is asthmaticus, which is an asthma exacerbation. Remember yesterday we talked about an ICS is not going to help with an asthma attack. It's used for maintenance. Now, if they are using March, then they're not using the ICS by itself. So really it's that lava that is helping the asthma attack, not necessarily ICS. But for those patients who are on the alternative therapy, they are on the ICS by itself. We're not going to use that in these cases. And then, of course, hypersensitivity to the drug. What questions do you guys have? Good? All right, so Kate R is a 45-year-old on QVAR ready Taylor, 80 micrograms, 2 puffs twice a day. What strength do you consider their ICS? QVAR, 80, 2 puffs twice a day. What's the generic for QVAR? Beclomethasone, good. And what quantity, what micrograms per day do you get for that? 4 puffs a day times 8, 80, 3. So we end up in this 200 to 400 range. So what strength is that? Medium. Okay? Again, TH is a 16-year-old recently prescribed Tomocort Flex Scaler, 1 to 80 micrograms, 1 puff twice a day. How many puffs a day? How many puffs per day? 2. How many micrograms per day? 360. And what's the generic of Tomocort? Just 9. So we end up here. So what's the strength? Low. Beautiful. Last one, BG is a 14-year-old on Advair Discus DPI, 250 per 50, 1 puff twice a day. How many puffs a day? 2 puffs a day. How many micrograms? 500. Okay, so make sure that you know these combo drugs when it gets a lot of them big. Which one of these strength numbers correlates to the ICS in that drug? What is Advair? Fluticasone, propionate, and salmeterol. So the 250 goes with fluticasone, propionate. The 50 goes with salmeterol. Okay, so 250 times 2 puffs a day, 500 micrograms. So we still end up in medium. So we had a number that was 300 and something before. It's very medium. Every drug is different. Okay? What questions do you guys have? Does everybody understand how to use these types of problems? Cool. All right, moving into LABAs, long-acting beta-2 agonists. They are all going to end in terol, and not albuterol and not levodopa. Everything else falls in this category. Okay? Asthma was misdiagnosed as having a bad active base. All right, so these are only available as a combo drug for asthma. When you get to COPD for exam 2, we are going to use LABAs by themselves. But right now, asthma, exam 1, we'll just focus on today, we're about tomorrow. They are all going to be in combination. So we are talking about the formoterol, salmeterol, and glycerol components, but never those drugs alone. That part makes sense. So Symbicort, a new brand name or a new brand generic for that one is Brana. So that just came out the beginning of last year, I believe. Dulera would be mometasone and formoterol. When you go back to what this chart said, which 3 options can be used as appropriate first-line therapy for maintenance control. Of these options, which 3 are preferred? Give me the brand name. Symbicort, Dulera, Brana. Why? ICS plus formoterol is preferred. So yes, we have these other options, but these other options fall into that ICS plus LABA. They are not the preferred first-line treatment. Okay? So when in doubt, the answer might just be Symbicort. If you're like, I really don't know, that's probably your safe say. In practice, I don't anything. Okay. I'm here to make sure you actually know the information. Okay? So we're seeing these in all of these spaces. Now we already know about the ICS component. We're going to learn about the LABA component and then put them all together. Sound good? You're also going to see some ICS plus LABA in steps 3, 4, and 5 as that alternative option. However, if we follow the alternative option for our maintenance therapy, then we need a short-acting beta-2 agonist or a SABA, or we need the ICS plus a SABA, which is why we don't want our patient to have to be on 2 different inhalers if we don't have to. But we do not have an ICS plus any LABA that you want as reliever therapy. Okay? So hypothetically, the question says, which of the following is the most appropriate treatment regimen for a patient with asthma? You have Symbicort. Hold on. You got Symbicort. You have Advair plus albuterol. You have, which one of those is preferred? Symbicort. But what about their reliever therapy? They can use the Symbicort for that too. Okay, so even though you only see one inhaler option as an option, doesn't necessarily mean that it's wrong or incomplete. You have to think about what drugs are in that drug. Make sense?
So moving to the medicine chemistry of long-acting beta agonists, probably for the most part, we're going to talk the structures, keeping in mind LABA and SABA at the same time, because some of these things which we are seeing right now, this is the SABA, but this is one LABA, so there's not a lot of difference between these drugs, except like how they look. We'll talk more in detail about it, but the SCR is more or less going to apply for both these drugs at the same time. Moving first, with respect to your albuterol, which is your SABA, salbuterol, and formoterol, having this substitution on the terminal amine over here causes less affinity, as you can see, less affinity to formao and more selectivity to beta-2. So this circles over here, the terminal amine substitution. So this substitution, this aliphatic substitution, and then there is some substitution here. There's a substitution here, which basically makes it more beta 2 selective and less affinity to MAO. Why MAO? MAO is an enzyme for metabolism. So if we have less affinity for MAO, it basically means the drug is not metabolizing, it's staying in the systemic circulation for a long time, getting more out of the drug than just getting it metabolized. Okay, so this is one of the SAR which you have to remember. And there is something called as long bulky aliphatic chain, which can also help basically for the drug to stay in the body for a longer time. So the only difference between salmeterol and albuterol, just as you see the structure, let's not get into the basics. What's the only difference you can see between these two drugs? Long, bulky aliphatic chains. Over here, if you see, it basically just differentiates your salmeterol versus an albuterol. Okay. Increase the lipophilicity and the length of action. And there is something called as catechol ring modification on the left side. If you can see those pink rectangles, so that lowers the affinity to COMT enzyme. And what is COMT for? Catechol-O-methyltransferase. And again, that is an enzyme for metabolism. So when we talk about catechol basically gets metabolized by catechol-O-methyltransferase. Okay, catechol is basically this structure over here. So any of those drug moieties which has this structure will always be vulnerable to COMT enzyme. So the idea behind this whole process and the synthesis of this drug structure is we have to get more out of this drug. It has to bind to the receptor. It has to stay as much as time possible to produce the effect before it gets eliminated. So they have synthesized these molecules in the same way. So you have to be responsible for all of it. Expect at least one question from a LABA and one question from a SABA standpoint, the medicinal chemistry alone, okay, in the exam. Moving forward, with respect to your actual mechanism of action for some of these drugs, short-acting beta-2 agonist, as you understand, this particular receptor looks like a GPCR, G protein coupled receptor. So we have your beta-2 agonist. Okay, let's do this carefully. Beta-2 agonist is any other drugs. Example of a beta-2 agonist. Albuterol. So albuterol binds here. It starts the cascade. So we're talking about the G protein cascade over here. So the drug binds to this receptor. What happens here? So it dislodges the alpha subunit from the alpha beta gamma subunit. It dislodges and it comes here and it activates. Initially, if you see in a 3D motion, if you don't have a drug, they're all together. When we have the drug, alpha dislodges, it activates your adenyl cyclase. What's next? This is your effector. This will activate your ATP to convert it to cyclic AMP. This cyclic AMP will further go on activate phosphorylate proteins which are responsible for the function. What function we are expecting here from a beta-2 agonist? What is the function we are looking here? Bronchodilation. So that is what we are going to be expecting. Between your cyclic AMP and phosphorylation, there should be something it has to do. What it's really trying to do here is, if you write down here, just open a bracket somewhere and write down, it decreases MLCK. Not mentioned here, but write down, decrease MLCK. MLCK stands for myosin light chain kinase. Decrease MLCK. MLCK is responsible for BC, bronchoconstriction. So if you decrease MLCK, cause bronchodilation. That's how you get there. Okay? There's one step before this, which you have to understand. Alright, and again, the cyclic AMP has vulnerability to be converted into an EMP. And again, we need this, we don't need this, and we don't need this. That's the reason this blue is highlighted. Okay, you understand? We are looking for cyclic AMP. We are not looking for ATP, we are not looking for anything out here. This is important to further prolongate or basically activate the other processes downstream to it. So one of the things why we have to care about is when you go back to COPD, we will read a drug which acts on this particular target. What is this enzyme? Phosphodiesterase. What is this enzyme responsible for? Converting cyclic to normal AMP. So we have a drug called as theophylline. We have other drugs like roflumilast. They inhibit this target. Let's think about it. If you inhibit this enzyme, cyclic AMP converts to AMP. There is more cyclic AMP means more protein kinase K means more bronchodilation. And then we skip that second step of MLCK, which basically means it will inhibit MLCK more. If more protein kinases means they are going to inhibit the MLCK, which is one of the enzymes responsible for constriction. Myosin basically means muscle associated protein, which is important for constriction. So you're going to reduce that activity. That's kind of like the whole process. If you have to just remember what the SABA does, SABA basically increases cyclic AMP levels to cause bronchodilation. Take home. The other things which you have to remember is desensitization. It's a very, very important phenomena of some of these drugs that if you keep using this drug time and again, this receptor over here gets downregulated. We'll call desensitization. How can we overcome this? And we can combine this with an ICS. That way the ICS has an ability to upregulate those beta 2 receptors and they can get some effect instead of getting no effect out of this SABA. Alright, so where are we going to place this in this whole diagram? The SABA over here. So it's basically acting on this phase of your structure of the airway. So it reduces the constriction caused because of most of these inflammatory mediators.
Alright, Brandon want to be included so bad, but we'll get to that in a bit. Brio, fluticasone, furoate, and cilantro. Please make sure you know the salt so that you can figure out the ICS. Okay, because there's two different types of fluticasone. Okay? This is going to be maybe preferred. It's 1 puff once a day. So if you have a patient who has trouble with adherence, I'll probably win. If you have a patient who has trouble with adherence, you're probably going to want something that's once a day, more than something that's twice a day, right? However, this is a DPI, so how do they have to breathe? Deeply and quickly. They got to get the powder out the capsule into their lungs. So if they're not interested in doing that, let's find something else, okay? Advair, also known as Rosella, also known as air duo Resticlip. Resticlip's probably not covered under most insurance. Fluticasone propionate, so a different fluticasone, but with salmeterol, 1 puff twice a day. But this one does come in an HFA. So how do we read that? Deeply and slowly. Which one of these options can we use a spacer with? The HFA. Was there any question?
Yes, Dr. Magali, is the furoate and propion? Is the furoate what makes it a salt?
Furoate is a salt.
And the propionate is
A different salt.
different salt.
So the ICS drug is fluticasone. That's either coupled with furoate salt or the propionate salt. And then that just goes into part of the mechanism or the duration of action. Okay? Dulera, Advair, and Symbicort and Brina are all going to be 2 puffs twice a day. So the 2 puffs is not really the issue, it's the twice a day that not really the issue. But if they only want an HFA, they are going to get DIE. Okay? Dulera, as we talked about, metazone formoterol, Advair, fluticasone, well that's this Advair HFA, fluticasone, propionate, and salmeterol. So same as up there, but not this is not HFA. Make sense? Okay. And then the Symbicort and Brina is budesonide and formoterol, still 2 puffs twice a day. This is probably the easiest combo slide to study as opposed to the other one that doesn't have. The picture helps a lot, especially if you already work in a pharmacy. And if you don't work in pharmacy, this will help a lot for when you do work in pharmacy because we're all going to be pharmacists. Alright, so some common side effects. So now we're just talking about the LABA component, not the ICS component. When they're on that combo drug, then you have the ADRs from before plus these. Okay? So headache, dizziness, throat irritation, pharyngitis, difficulty speaking, and GI discomfort. When you think about how a beta-2 agonist works, the headache, dizziness, They kind of make sense. Okay? But it's still acting on those beta 2 receptors. Not as much, not in the same capacity, but it's still happening. So sometimes when the dose is too high, this is the result. With poor technique, throat irritation, pharyngitis, and difficulty speaking. Okay? Some rare but serious AFib. Why? It's still a beta 2 antagonist. Okay? Paradoxical bronchospasm. So this is what we were talking about yesterday. This is using it too often can bring back the bronchospasms that were the reason why you took it in the first place. So sometimes we may need to increase the dose so that we can decrease the frequency. Sense? In which situation is the patient most likely to experience paradoxical bronchospasm? When they're using their inhaler for what? Rescue. Because remember, we can use this as march, maintenance, and reliever therapy. So if I'm using it for that and reliever therapy, that 2 puffs every 4 to 6 hours is different. That's not the case here. Some people are so used to, oh, I used to be on Adderall or Albuterol this whole time, and I got switched, but they're so used to 2 puffs every 4 to 6 hours as needed, short of breath. That they're still doing 2 puffs every 4 to 6 hours as needed, short of breath. Okay? There is a black box warning when you're using a LABA by itself. Which we'll just jump to this. Asthma-related death. If you have a patient who does not have asthma, they should not be on a LABA. Which is why yesterday we talked about step number 2, confirm that they actually have asthma. So that you can make sure that the medications that they're on are correct. Which is why even though we do not make the diagnosis, I need to know how to know that this is the correct diagnosis. Okay? So this study came out several years ago with salmeterol being the LABA of choice compared to a placebo. And 13 deaths out of 13,000 patients who were on salmeterol alone compared to 3 out of 13,000 who were on a placebo. Okay? The studies have shown that in combination there is no increased risk of death. So when we combine that LABA with that ICS, we basically eliminate that risk of asthma-related death. Okay? No increased risk of exacerbations or hospitalizations when it was added to the ICS. So this is all you really need to know. Like this is why I put it on top. Say that as a PDF and you can't see the PowerPoint version. I know that yes. This is the answer to the question on the test. I'm literally trying to give y'all the answers because nobody wants to believe, right? Okay. Always be combined with ICS. You good? Always be combined with ICS. Beautiful. What are we monitoring for? Again, still the frequency of their reliever use, regardless of what reliever they're on. Right now, we're not talking about the murderer only. We're talking about all of the LABAs. So whether they're on a salvo for their reliever or they're on March, how often are they using their reliever? How adherent are they? What are those PEFs? We're going to talk about that maybe tomorrow. Precautions. So don't initiate it in a patient who's rapidly deteriorating. Because why? How long is a LABA taking to work? A while. Do we have a while? No, we do not. So what do we need instead? A SABA. Okay, we need something that's going to act quickly because time is of the essence. We're going to avoid use with the CYP3A4 inhibitor, avoid use with asthma exacerbation, status asthmaticus, whatever you call it, and then avoid using it as monotherapy. You guys see how a lot of this is like overlapping and repeating? It's kind of the same, but not. So when you're studying, make sure you know the differences. Because a lot of it is the same. But what we're not monitoring for here, that we are monitoring for the ICS. Thrush. So if it says select all that apply, what are the drugs in it? The side effects and all that is mostly the same. Okay? Study the differences will save you a lot of time. All right, getting into short activated agonists. Any questions so far? All right, so we have albuterol, which is pro-air, pro-ventil, Ventolin, vent. They're trying to be able to ventilate on their own faster. 2 puffs every 4 to 6 hours as needed for shortness of breath. 2 puffs 15 to 30 minutes before exercise. Generally, I just tell people 20. 20 minutes is a nice even. You already have it, you don't need to take a picture, and that's weird.
This slide's up.
Oh, if you don't have it, you don't need it. I gotta make sure I have it. Articles test is how I'm going to do it. Well, we're all 2 puffs every 4 to 6 hours as needed for shortness of breath. See how it repeats. They both have 200 puffs per pinch. This will probably pop up later, and that's what will make more sense for you to have. Okay? So where do we see SABs? What about now? So should we have a lot of patients who are on albuterol as they're really prepared for asthma? Should we know? Will we? Yes. Which is why we still need to know how to manage it, how to look at it, what to look for, what to be worried about, etc. Okay?
Same as diarrhea.
Again. Or do you want to take a break?
All right, so we're going to take a break, and then we're going to come back at the 27th. By the 30th, I want to be taking us home, okay?
Thank you. Sharing the screen. Sharing the screen. 27? 27.
Good boy.
All right, we're going to get started. So go ahead and head back to your seat. If you don't see your friends, call them or not. That's between you and your friends.
Alright guys, we're picking up from where we left. So again, we're looking at the structure-activity relationship now in the context of SABA. Okay, but you can still see salmeterol and formoterol are showing just kind of like to differentiate between these drugs. Okay, can I just point out one difference between your drugs, which are probably the first 4 versus the last 2? The long chain. The long chain aliphatic chain basically lets it stay in the body for a longer time, and that's the reason they are long acting. It means they have at least 12 hours to be there in the systemic circulation, not less, compared to your SABAs, which probably should be around 3 to 4. Moving to your structure activity relationship, you always have to understand that before SABA or the drugs which are more selective for beta 2 were existing, there were drugs like norepinephrine and epinephrine which were used. Okay, and they went on to basically identify more selectivity because we really need to target the beta 2 receptor instead of like alpha 1, alpha 2, beta 1, and beta 2. The way I remember it, just note this down. Whenever norepinephrine comes to your mind, nor starts with an N basically means not all. Epinephrine means it starts with an E or an adrenaline, A means all. The only difference between norepinephrine and epinephrine with respect to which receptors it targets, epinephrine targets all the receptors. All the receptors means alpha 1, alpha 2, beta 1, beta 2. Gotcha? Norepinephrine, not all. So what are you looking at? Alpha 1, alpha 2, to some extent beta 1 or beta 2. We don't know, but it doesn't target all of it. Epinephrine is more potent than norepinephrine. Okay? So scientists have been using it. So you imagine a situation when a person, before we had the SABAs, were given epinephrine and norepinephrine. What are we expecting? This drug is going to be used as an inhaler, imagine. Again, these are all hypothetical situations. We have an inhaler which is epinephrine. What are we really doing to the patient? We are hitting all the receptors. We are expecting all the adverse effects. And the adverse effect which we really don't want is the beta 1 adverse effects, like atrial fibrillation, okay, tachycardia, because it's an agonist. It's going to hit beta 1 very strongly, and a beta 2. We get something good out of beta 2, but we also produce heart complications, which we really don't want. So they moved on to make isoproterenol, which is selective beta, non-selective beta agonist. Non-selective means it still acts on beta 1 and beta 2. Moving on, they started synthesizing albuterol. So what is the only difference between your isoproterenol and your albuterol? It's probably the side chain, okay? It has more aliphatic chain, the terminal amine saturation. So that is the first SCR over here for you guys. The more we have those side chains, the more selectivity is moving from your alpha to your beta 2. Okay? So the more side chain on the terminal amine, the more more selectivity towards your beta 2. And again, this side chain can also help for lower affinity for MAO, which we have already discussed. They are all mixed acting. They act on both alpha and beta receptors. Whereas albuterol is quote unquote beta 2 agonist. But again, if you use in concentration more than what is actually prescribed, you will end up hitting beta 1 and give a rare serious side effect, which we have already seen in the last slide. Okay. Moving on, the catechol ring modification, the COMT on the left side. This is your catechol nucleus. So they're basically having this catechol nucleus, it lowers the affinity for COMT. One of the things which we also have to probably talk about, and there's probably not a lot of evidence out there about albuterol versus live-albuterol. The only difference between live-albuterol is this structure of albuterol, this OH group over here, is kind of like, it's a racemic mixture. It's kind of flipped in the opposite direction. And they think that any levo form is more potent, we need less amount of the drug, but there is hardly any evidence out there which shows that levo-albuterol is much better with respect to its potency, with respect to its side effect profile, with respect to its ability to bind to which receptors like the beta 2 or a beta 1. This body is still in the learning phase, but that's kind of like the structure for levo-albuterol. All right. So again, to sum it up, terminal amine substitution is an important structure activity relationship point which we have to remember. Having a terminal amine will help first to increase the beta 2 selectivity, second, lower the affinity to MAO. Second SCR is catechol ring modification. Having that side chain on your catechol ring basically will lower affinity for COMT enzyme. And I think this is just your FYI, the liver-albuterol. So here's your knowledge check. Which part of the molecule is responsible for beta 2 selectivity? So we have 1, 2, 3, and 4. Which part of the molecule is responsible for lowering the affinity to COMT? 3 or 4? 1, 2, 3, 4. So how many people say 3? Raise your hand. How many people say 4? Why not 3? It's basically the whole nucleus is what we are considering, not just a small nucleus. So we can get confused. Catechol is not without OH. Catechol is always with an OH group. So that's the distinct factor you have to remember. So the answer should be 4. And the final one is which part of the molecule is when rotated forms the drug albuterol, leave albuterol, sorry. So which part of the molecule? Answer should be two. Alright. It's the same mechanism we have discussed this again in the context of SABA. This slide will have at least one but not two questions in the exam. I'm telling you. It's a very, very important slide. It kind of fleshes out why each receptor, where it's present, and what we can expect. And you have to know the adverse effects. And the reason just not knowing it, why is it even happening in first place? Okay, so let's go one by one. What are we expecting to when we stimulate a beta 2 receptor in an airway? Beta 2 is bronchodilation, right, or relaxation. So you expect all those effects with a beta 2 stimulation of your smooth muscles. It also causes increase in ciliary beat, ciliary secretion, and inhibition of mast cell degranulation. What is mast cell degranulation? We said that ICS is helping your SABA, but we can also see like your SABA is also trying to do some kind of anti-inflammation because you're inhibiting a mast cell degranulation, which means like decreasing the release of histamine, which can cause inflammation. So it goes both ways. Alpha, especially alpha 1. Alpha 1 is equal to, we got the formula in the first year. Vasoconstriction. Alpha 1 is VC, beta 2 is BDL, bronchodilation. Okay, so we expect vasoconstriction, but in the context of your bronchial smooth muscle, this can cause bronchoconstriction, especially with alpha. There's not many alphas around your bronchial smooth muscle. If at all there is, then this causes bronchoconstriction. Your heart. This is one of the important players, and that's one of the whole. Like, if you cannot remember anything, please focus on the heart-related adverse effects, which we can expect if you use this drug more than what actually has been prescribed. So we have beta 1 and we have an inotropic and chronotropic effect. What's inotropic? And what's chronotropic?
Chronotropic is like time, like increase heart rate.
Yeah. So which is heart rate? Which is force of contraction?
Inotropic.
Inotropic is force of contraction. Chronotropic is your heart rate. So it basically increases your heart rate and force of contraction. Your beta 2 basically is responsible for chronotropic effect. Okay. Then coming on to vasculature, you have beta 2 vasodilation as expected because most of your beta 2 causes vasodilation, whether it's a bronchial smooth muscles or any other muscles in the body. Skeletal muscles, again, please highlight this. This is a very important adverse effect. Beta 2 can slowly sneak through and activate your skeletal muscles. What are we expecting? So these people who are on SABAs alone or probably LABAs, I don't know if LABA is given alone, but again, from scientist perspective, if anyone is using these drugs for a longer period of time, they can expect tremors in their hands because it's going to stimulate some of the receptors in your skeletal muscles to cause tremors. Uterus, it causes relaxation, and your metabolism. Metabolic basically means like these drugs are going to act on your beta 1 and beta 2 cause glycogenolysis and gluconeogenesis. What are these terms called? Glycogenolysis is breakdown of glycogen. Breaking down of glycogen leads to increased glucose, leads to increased propensity to become more diabetic. So you basically are taking the asthma away to give a diabetes to a patient. So we just have to be watchful for these effects, especially when it's not used as prescribed, because it can activate a lot of other receptors to cause these problems. Okay. One other thing which you also have to note is hypokalemia. It causes decrease in potassium levels in the systemic circulation. I'm not going to talk about the mechanism, but this is one of the important effects. So what we have to remember, your beta 1 effects, your beta 2 effects, your alpha 1 effects. So when it comes to beta 1 is in your heart, inotropic, chronotropic, you cannot forget it. Beta 2 is in your bronchial smooth muscles, bronchodilation. But there is also beta 2 in your skeletal muscles, which causes tremors. That's an important side effect for watching. And beta 1 and beta 2 is also present to cause increase in blood glucose levels by doing glycogenolysis and gluconeogenesis. So you just have to watch for those side effects as well. All right? Any questions? All right. I will have a knowledge check after this. Are we all on the same page? You have to answer those knowledge check. Okay? Let's go one by one. Match the therapeutic effect resultant of the use of SABAs with the receptor stimulated. Dilation of bronchial smooth muscles. Which receptor? You have to mention me the name of the receptor here. Which receptor is responsible for dilation of bronchial smooth muscles? Vasodilation of large vessels. Vasodilation. Alpha 1 is never dilation. Alpha 1 is VC. You cannot go wrong there. So then it's beta 2 again. Muscle degranulation, decrease. Alright. So let's move to the adverse effects. So what did you notice so far? The therapeutic effects is all your beta 2. Let's move to the adverse effects. Chronotropic and inotropic. Alright. So it's chronotropic and inotropic in the heart, it's basically beta 1. Hand tremors. Glycogenolysis. Beta 1 or beta 2? Beta 1. Gluconeogenesis is beta 2. Hypokalemia is the last one, beta 2 again. Alright. You will have a couple of questions in the exam. Alright. So just get the basics correct. You will not learn this again. This is the last time, and then we pick it up only in probably advanced PT or something. So just make sure that you know what all these things really mean. Oh, there's one more knowledge. What is it? Alpha 1 or beta 1? I don't know about alpha 1, but I really know about beta 1. Different textbooks talk. Does it say that alpha 1 over there?
Oh, the bottom red
Gluconeogenesis is beta 2. Glycogenolysis is beta 1. And alpha as well to some extent. I would not put my bet on alpha because I remember alpha as only vasoconstriction. That's the most important effect. Okay, it's all about the beta. Sorry. So let's just do this quickly, please. A patient with acute bronchospasm is administered albuterol within minutes. Again, I'm giving you a quick snapshot of my questions, how it will look in the exam. Okay, so please practice. Get used to like reading this big paragraphs. Within minutes, they experience tremors and a rapid heartbeat. Which pharmacological action best explain the side effects? Beta 2 receptor stimulation of your skeletal muscles, which we discussed. The hand tremors basically is coming from that, and the beta 1 in your heart is what we expect. Why does salmeterol provide a longer bronchodilation than an albuterol? Long lipophilic side chain. Moving forward, how does beta 2 receptor activation by SABA leads to bronchodilation at the cellular level? Mediated inactivation of a myosin light chain kinase. Okay, that is what everyone knows about bronchodilation, beta 2 bronchodilation. But a good student knows that there is a myosin light chain kinase inactivation which leads to bronchodilation. Okay, if you can remember that, it will differentiate you from what is actually important to know. Patient is using albuterol more than 4 times daily and reports reduced effectiveness. What is most likely explanation for this reduced response? Beta 2 receptor desensitization due to frequent stimulation. There is not many ways I can ask this question. If you're practicing this, you hopefully would have mix and match of synonymous ways of asking the same thing again. All right, so I expect everyone to do really well on this type of questions. Okay, and again, this is the place where, on the whole structure, is where we expect the beta agonist to act. All right.
All right. So we just talked about all of the beta 1 and beta 2 effects. So that should explain these common side effects. Yes. Cool. So nervousness, tremor. We say hand tremor, but it's not always just tremors in the hand. Okay? Because where else do we have skeletal muscle or skeletal tissue? Everywhere. Okay, so it could be a foot tremor, it could be a leg tremor, elbow tremor, tremors. Okay? Tachycardia, fast heart rate or slow heart rate. Beautiful. Palpitations and cough. Less common but more serious. Back to that paradoxical bronchospasm. When is the patient most likely to experience that? And they're using it for rescue. Good. Atrial fibrillation is in large doses. This goes back to what Dr. Muhammad was talking about: hyperglycemia, hypokalemia, and hypertension. Okay, so what are some things you think we're going to monitor for on patients who are on SABA? Blood sugar. blood pressure,
and that's
potassium,
yeah, that's it. So
and heart rate. Good. Beautiful. All here. So we want to figure out how often are they using that style. So how many days per week is probably the most effective units of measure. The PEF, we're going to talk. We'll get into it today. This problem. Heart rate, blood pressure, blood glucose, potassium, and other PFTs. Okay? What are some precautions? So careful in patients who have uncontrolled cardiovascular disorders. The question says the patient has hypertension, hypertension, diabetes, and asthma. Oh my. They are currently on and see medications for hypertension. Would you recommend a solid? Why? Why? Mm-hmm.
All these medicines couldn't worsen.
Beautiful. Their hypertension is controlled, but I'm never going to recommend the solid as the most appropriate treatment. Every question is going to say which of the following is most appropriate. Okay? If it's uncontrolled, you don't see any medications on your profile for anything that should be treating or controlling your hypertension, we're still not going to recommend the solid. Okay? If we have to go the alternative route, then we need that hypertension to be controlled first. Does that make sense? Good. Non-selective beta blockers may also lessen the effect of SABA, and then, of course, contraindicated in patients with hypersensitivity. So then there's this argument about levodopa versus albuterol. Albuterol is the R isomer that was made to hopefully decrease the side effect of the tachycardia that comes from albuterol. However, they did some studies and they found, bullet number 2, not clinically significant difference in the tachycardia between the two. So some studies may show that pediatric patients may have more of a benefit, but as most of our patients are likely going to be adults, they are probably not going to notice that much of a difference. Yes?
so you said that that slide part that you don't give SAWA to like people that have uncontrolled cardiovascular disease.
Correct.
If the patient has like a normal blood pressure and it's enough like medication for its hypertension or arrhythmia, do we still give SAWA or we
So
should?
it's never going to be most appropriate if other options are on the table, simply because of all the other side effects. But if you had to, you want to make sure that those cardiovascular conditions are controlled as much as possible first. Yeah, yes.
So what do you give instead? So sort of whatever. But so
To get the heart controlled first.
I mean, like if you're not giving SAWA, then what other?
That's our only option. So we have to get the blood pressure under control first. So you could go the lifestyle modification route. If you're like, I'm not taking any more meds, I'm already doing too many. We need to get a 30-minute walk in every single day. We need to drink more water. We need to dash diet. We need less than 1 gram of sodium a day. Like, if you're not going to do that, we have to take the non-farm route to control the heart conditions so that we can treat the asthma or the breathing, whatever is going on with the solid if we have to use that solid.
So the clinical inertia for treating hypertension is pretty quick. So if a patient came with uncontrolled hypertension and also having asthma, you could literally put them on medication because you guys will learn this when you get the hypertension, but like patients are always willing to do the non-pharm implications. And if you guys come on rotation with me, you will see my patients always say, Dr. Grisby, I want to do the non-pharm. And the next week, the blood pressure is still the same. So if you put them on medication, you can get the mechanism of action really for the drugs. The blood pressure will start being lower kind of immediate. So you could see them 1 week, put them on blood pressure medication, have the blood pressure progressing towards control, and then starting the solid. But if the blood pressure is completely uncontrolled, giving them the solid is only going to exacerbate another issue that's going to send them to the hospital quicker.
If you have a patient who maybe comes in acute asthma, patient also has a high blood pressure. Delay asthma, take care of that. Just at that point, take care of check the blood pressure.
So yeah, you'll get two clinical perspectives. You'll get mine and you'll get Dr. McCullough's. So we can move forward with class. But me, how I see things, I do everything in real time. So I probably would treat both at the same time. So I would go ahead and start something for the blood pressure as well as get something going for the asthma, knowing that with treatment for both happening, the synergy of the treatment for both is going to lead the patient to have better outcomes.
Same. Is my answer.
And that'll come up at the end of tomorrow. Okay. All right, leukotriene modifiers. How many of y'all have ever seen this episode of That's Already?
Yeah.
Okay, do you know what was happening to her in this episode of That's Already? I heard it.
I don't remember, but I think
She had an allergic reaction, so many people probably don't lose leukotrienes. When the patient also has allergies. So the question says, the patient also has allergies. This is on the table. Okay, my tips are not like just English, but they are really sharp. So where do we see leukotrienes being used? Okay, step 5, where else? 4, 3, 2. So alternative track 1 options. So back to somebody asked a question earlier of how do we pick between track 1 and track 2, alternative and primary. If the patient also has allergies, we may consider this regimen instead. Okay?
Alright, just looking at the mechanism of leukotriene modifiers. They basically call as leukotriene antagonists to some extent. You have seen this particular cycle of arachidonic acid in the past, but what we haven't seen basically is there are two pathways which arachidonic acid always leads into. One is your prostaglandins pathway, which we discussed in your self-care NSAIDs lecture. The other one is your leukotrienes pathway. That's what one of the things which I was telling you yesterday is in aspirin-induced asthma. Aspirin can induce an asthma only because aspirin is able to inhibit one pathway, but arachidonic acid can still form leukotrienes and end up causing binding to receptors to cause bronchoconstriction. How we can really help these patients by having drugs which can act as antagonists of these receptors called cistanide leukotriene receptors. One thing you have to be very careful is you see whenever this antagonist comes from mind, especially with leukotrienes, it's a competitive antagonism. You have to know this. It's just not normal antagonism. It's a competitive antagonism. What it means is for the same receptor, we have a drug and an actual leukotriene fighting for it. Whichever wins the race, which basically would be for the most part because an antagonist. What is the idea? What is the feature of an antagonist? It has more affinity than an agonist to the receptor side. So it always has more ability to go and block the receptor. And once the leukotriene blocks the receptor, when this Laffer-Lucas or Monte-Lucas blocks the receptor, the actual leukotriene cannot access the site. And if the actual leukotriene doesn't access the site, what are we not expecting to come? All the adverse effects associated with leukotrienes, like bronchoconstriction, inflammation, and stuff. Okay, let me walk you through the pathway. So we have your arachidonic acid getting converted into 5-lipoxygenase, which further gets converted into leukotrienes A4, B4, C4, D4, and E4. Okay. So this leukotriene B4 is a chemoattractant. Just put that in the bracket over here. We're not going to talk more about B4 because it doesn't have a lot in the context of what we really want. But what we really are going to be focused on is your C4, D4, and E4. And remember in the first class I told you that there was one leukotriene which has 1,000 times more potency than histamine. It belongs to one of this. It's probably C or D. I'll just probably cross-check on the textbook again. But they have 1,000 times more potency to cause bronchoconstriction compared to histamine. This leukotrienes can bind to a cistanide leukotriene receptor and cause bronchoconstriction. So when we take drugs like Monte-Lucas and Zafir-Lucas, they have competitive antagonism. So they block the receptor. So this leukotrienes cannot access. That way there is no deleterious adverse effect associated with this particular leukotrienes. There's another class of drugs called as xylitol, which is a 5-lipoxygenase inhibitor. Where is 5-lipoxygenase here? There. Yeah. So it's basically the bridge between your arachidonic acid and your leukotriene pathways. So basically the eicosapentaenoic acid. So if you use a drug called xylitol, it inhibits 5-lipoxygenase. You basically, even before the cycle of leukotriene starts, you're inhibiting it. So this, I don't know how much it is clinically used, but if I was a scientist, I would basically prefer using xylitol more. We don't know what the adverse effects of this drug yet, but because it inhibits all the leukotrienes to even form if we inhibit it at this phase instead of inhibiting at the phase where it's already formed and now we're trying to prevent it. Okay, so that's one of the class of drugs which is out there. And again, the idea behind this whole class of drugs is to kind of reduce the inflammation, so they basically help to alleviate. So whatever leukotrienes are formed, we cannot really do anything, but we can basically try to prevent further inflammation. So that will lead to increased asthma control. So we're talking about leukotrienes on this pathway. Go ahead, Jose.
Yes, so it sounds in theory that the second mechanism, the kiloton, would be stronger, but sometimes clinically it doesn't show a difference. Is that the case? Like, is siloton a stronger?
A pharmacological way, I can answer that from pharmacological perspective. I would put my money on xylitol than on montelukast because I'm going to inhibit all the leukotriene. But how it phases out in a clinical setting is something we have to watch out because especially with the drug as it looks on how beautiful on this is basically me pitching a drug to an investor to basically put money on my drug. It's like, oh, you know what, everything looks good, but in reality the side effects, the therapeutic profile, the precautions we have to take when we use this drug, how far from the allergic reaction or asthma reaction we can take it, what's the half-life, what's the dosing, all those things, the considerations, the clinical goals are important. I think Dr. Macaulay would speak to it as she's going to talk more about it. So that way it may or may not be the best drug. But again, we have to look from those perspectives. One is like the synthesis, the other one is like the usage of that drug. Okay?
All right, so good question. To quickly answer that, xylitol is most commonly used right now to treat asthma, aspirin-induced asthma. Okay, so a patient with asthma be taking aspirin. No. So what we really try to use is as maintenance more often than not. They don't know yet. So when you don't know and you're not sure, we're gonna go with montelukast. Okay. Right now, montelukast is indicated. Well, montelukast is indicated for children. So for 1 to 5 years, 4 milligrams daily in the evenings. 6 to 14, 5 milligrams in the evening, 15 and up, 10 milligrams. Zarfilukast for athletes 5 to 11 years, 10 milligrams twice a day. So by default, is this more preferred or less preferred than montelukast? Less. Why? Twice daily dose. So if I have to use it more often to get the most benefit and the adherence is not best, you're missing more doses by default. Okay? These also need to be taken 1 hour before meals and 2 hours after meals. How many of us are up and ready to take medication an hour before breakfast? Because y'all can't hear it, but I did it. I was the same way. I've been there. Xylitol for 12 years and older, 600 milligrams 4 times a day. So how do you feel about it now? Yeah, y'all was like, I'm crazy. I didn't pay you. But yes, 4 times a day. So clinically, statistically significant, yes. Clinically significant. I mean, if you get all 4 doses all the time, maybe. Okay. So our LTM of choice is going to be the montelukast. Okay. At this point, I'm not going to ask you to pick between 3. You are not a resident. It's going to be by 2. I'm just going to know how to manage that. Okay. All right. Some common side effects: headache, dizziness, dyspepsia, abdominal discomfort. What is dyspepsia? Difficulty swallowing, kind of Google the screen. I'm always going to say that. Google the screen. Indigestion. Is indigestion the same thing as GERD? No. Good. Less common but much more serious liver issues. So increased LFTs and hepatitis. So what do you think we're going to be monitoring for? Liver. What labs do you think we're looking for? LFTs. What letter does this drug class start with? L. So put all the L's together. Okay. LFTs need to check your liver. Neuropsychiatric reactions as well. So aggressive behavior, altered behavior, suicidal thoughts, and sleep disturbances. So would we prefer this in a pediatric patient? No. Okay. Those are those patient-specific situations that I want to be mindful of because there's a black box warning for it as well. Okay. So the risk of neuropsychiatric events right now, the study was done with Montelukast, so this is what the black box warning says, but the warning is for the drug class. Okay? So we want to make sure that we counsel these patients on this. We want to let them know if you notice any changes in your mood, in your mental status, any changes in aggressive behavior, please let us know right away and stop taking the medication. Was this mostly on track 1 or track 2? Track 2. So do we have other options? What else can we use to treat allergies? Securities, Zyrtec, Claritin. Do we have options? So we don't have to go this route if we run into this issue. Okay? What is the number one priority as a pharmacist? Safety. Okay? So what are we monitoring for? Peak expiratory flow again. Frequency of rescue inhaler use. You're going to see that every single time. And then LFTs at baseline. We need to know how they started so that we can be aware of whether or not they're getting worse. Okay? Precautions, as we talked about, black box warning for neuropsychiatric events, not to use in an acute asthma attack. So we have to put this in one of two categories. Which one do we put it in? Maintenance or reliever? Maintenance. So if it's in maintenance, it's going to help with a reliever. No, it is not. Okay? Sometimes this can cause eosinophilic symptoms, so we may want to monitor that, check for that. But we usually don't unless we have to. So then the question comes, well, where do we use it? Why do we use it? Why do we prefer it? In situations, this is going to always be less effective than ICS as monotherapy or in combination for asthma. So we're never going to use a leukotriene modifier by itself. We're always going to couple it with an ICS or an ICS plus a lot. Okay? However, patients who also have allergic rhinitis, this is a good option to add on therapy. Patients who may be unwilling or unable to take an ICS. Because if they don't want the ICS, can we give them just a lot? No. So then we need to give them this. And then we're kind of stuck with what else do we do? You can also give it to patients who experience intolerable side effects from ICS treatment. So sometimes you can bargain with the patient, well, what if we give you a lower dose of the ICS and then we'll add this on to kind of fill in the gap. Does that make sense? But when is the most common time that we're probably going to add this on as therapy? When the patient has allergies. Okay? And what labs are we looking for? LFTs. So you can see down here where you find the trains to kind of put the whole thing back together. 2, 3, 4, 5, beautiful. All right, LAMAs. The only LAMA that we are going to use in treatment of asthma is tiotropium. Okay? Ipratropium starts with an I. The letter I is short. So that is a SOM, short-acting. Tiotropium starts with T for tall. That is a long-acting. Okay, so you're trying to remember which one, because we are going to talk about ipratropium later. But that is going to be for reliever therapy because it's short-acting. T for tall, long-acting. You good? So where do we see LAMAs? And at the farm. Where else? Step 4 and 5. So how often are we going to start a patient on a line? Not often. Remember, we usually start them on step 2 or 3. Okay? This is for patients who are 6 and older. They have to be at least 6. They also have to have asthma that is not very well controlled with the ICS plus a lot. Okay, it's going to give them modest improvement in their lung function, modest delays in time to exacerbation. So we do have some benefits, but it's not significant. And this is the only one that works in asthma. 2 puffs once a day. This is all you need to know about lungs. You'll learn a lot more about it in COPD. Okay? You guys will probably need to start part 2. Getting already down with it. 30 seconds to do so. Yeah.
So for step 2, can you do it as by itself?
I mean, you can. You might end up starting up to step 3. Because I'm not happy. Alright, is everybody ready? Cool. So moving into biologics, so monoclonal antibodies, is there an antibody out there? These are all going to look like this structure and function. Okay? Where do we see biologics? 5. So that are we ever going to start a patient on a biologic? So if the question says we're initiating a patient on asthma medication, which of the following is most appropriate? And one of those answer options is a biologic. Are you going to pick it? No. Because you are initiating them on treatment and never start on step 5. Okay? This study guide is probably as much of a study guide as I'm going to make, but I'm going to make a table and you can fill the rest. If you would prefer to fill this in while we teach it, that would be just as sufficient. Okay? This is all you need to know about biologics. That is for my portion. Sense?
With the biological agents, we are looking at the targets. And again, for my portion, what I really want you to understand and just take away from right now is which drug and what's the target. If you're able to just memorize this part of this whole slide, I think you should be able to at least get through the exam. Okay. So how does this all drugs fit in this particular cycle, which we have discussed, and I'm going to talk about this again. So we have a person who is exposed to an allergen. That allergen comes down to an antigen-presenting cell, which then engenders a Th2 phenotype activation. Why Th2? Why not Th1? We're looking at a patient who is asthmatic, not a person who is normal. So there's always a Th2 bias versus a Th1 bias for people who are diagnosed with asthma. So Th2 activation causes release of all those inflammatory mediators. We have talked about IL-4, IL-5, IL-13, and then this IL-4, 5, and 13 will go and activate your plasma cells to cause what? Release of IgE, right? So this is the first exposure, right? So we have been exposed to an allergen, which is kind of an antigen. We formed an antibody called IgE. This IgE has a site where it goes and sits, and the site for this IgE is your mast cell. It's sitting on a mast cell waiting for the person to get exposed to an antigen again, the same allergen. As soon as the person gets exposed to the same allergen again, that's when that allergen can bind to an IgE to prime this mast cell to release histamine, leukotrienes, platelet activating factor, and all of those inflammatory mediators. They all together will combine to produce a cascade of inflammation to cause an acute asthmatic response, which is probably a couple of hours into the attack. And this acute asthmatic reaction is associated with constriction, edema, and mucus production, whereas over a period of time, all of those in an acute phase will keep on causing structural changes. That's when we look at a chronic asthmatic reaction. In addition to that, bronchoconstriction, mucus hypersecretion, inflammation, bronchial hyperreactivity, bronchial sensitivity, there is also structural changes, like three of them we discussed: subepithelial fibrosis, right? Goblet cell hyperplasia, and increased cells, smooth muscle cells, the hypertrophy and hyperplasia of smooth muscle cells as such, causing constriction. And this, the whole umbrella term of structural changes can also be summed as airway remodeling. And that's your chronic asthmatic reaction. So I've summed up my first day of the lecture right now with this particular slide. All right. So here we have drugs like benralizumab. Anything which ends with an mab is a monoclonal antibody. Okay. So these drugs are out there which are antagonizing an IL-5 receptor. So where is IL-5 here? Do you see there? IL-5. So this IL-5 has to bind to this particular receptor. So if you basically antagonize a receptor, because this drug has antagonist, and again coming back to the pharmacology, antagonists have more affinity to the receptor than an agonist. They go and block the receptor side. IL-5 cannot bind to it. No IL-5 binding leads to no receptor activation. No receptor activation leads to no whatever effect. And what effect we're looking at right now? The inflammation. Okay. The second one is mepolizumab and rituximab. They bind to IL-5 by itself. There is a difference between drug binding to a receptor versus binding to IL-5. What is the difference? R and no R. Is that the difference? I mean, that is a difference. Bind to a receptor as an antagonist versus binding to IL-5. You basically have an antibody which binds to an IL-5. What is IL-5 here? An antigen. Right? So antibody can bind to an antigen, form a complex. So no more IL-5 circulating in your blood. No IL-5 circulating in the blood leads to whatever the downstream effects which you can expect when IL-5 binds to a receptor. So that IL-5 cannot go and bind to the receptor, and we don't expect a lot of inflammation. And then we have dupilumab. It binds to a receptor for IL-4 and also IL-13. So by now you should be able to understand what are the three important interleukins we have read so far: 4, 5, 13. And you should be knowing the functions of each of them. 5 is always your eosinophil. What is 4? The IgE. What is 13? Alright. So here we have basically whatever I've explained so far. This is again in so many words. I'll leave this for you guys to kind of figure out. But one of the things which you have to really understand here is omalizumab, which we haven't discussed. This is a specific drug which is an IgE specific monoclonal antibody. So it binds to your IgE. Remember where we say IgE? Over here. So if omalizumab binds to your IgE, what will happen? IgE, which is basically your Y, if omalizumab comes and sits here, can omalizumab, that antibody, can go and prime this mast cell? No priming of mast cell leads to no degranulation. No degranulation leads to no histamine. No histamine leads to no bronchoconstriction. No bronchoconstriction leads to helping patients with the symptoms of asthma. Okay. So here we have all the information which we have discussed already. So omalizumab, as you can see, can bind to the IgE, and IgE is not free to go and prime the mast cell. Chapter closed. Great. Moving forward. Oh, that's clinical.
Alright, so the first one we're going to talk about is omalizumab. So there, please note brand names. Okay, if you want to take the logo of the brand name, it already has the route also. The brand, generic, and the route already on. So I like to use those kind of study with because I have everything already there. What is indicated for allergic asthma? They have to have a positive skin test. So we can't just say, listen, that they have allergic asthma and be like, oh, let's start on it. We have to do these tests first. Okay? Indicated for patients who are 6 and over. Subcutaneous injection every 2 or 4 weeks. You go back to the chart that I gave you before, it really just says route and frequency. The strength, as you see, isn't here because right now it's not. Okay? Subcutaneous every 2 or 4 weeks. These do have to be initiated in a healthcare setting under medical supervision for at least 3 doses. Because remember, this is a monoclonal antibody. So there's a lot of things that can happen in anaphylaxis that we want to make sure that the person's body is tolerating it properly before we let them go home and inject it themselves. Okay? Where is it stored? Where are all of them stored? In the refrigerator. So you can honestly take that bottom row where it's in storage, it's right in the refrigerator all the way across. Okay? Adverse effects, anaphylaxis, however, although we only need the first 3 doses done in the healthcare setting, this can show up at any given dose, even a year after being on the medication. So very similar to how a dry cough can happen with ACE inhibitor at any time, this can happen at any time. Yes.
So when you dispense like an EpiPen medication,
You probably should. Alright, so reslizumab and mepolizumab, and then we'll go into that one as well.
Alright, so we have discussed about this. What I really want you to know is the drug target. So I will give you a drug and you have to know whether it's an IL-5, 4 or 13. Simple. But this is kind of like an example where we have a monoclonal antibody. We have an IL-5 and it's trying to access it. So remember, these are IL-5 antibodies. So we have your monoclonal antibody like reslizumab can bind to this receptor over here, which will prevent IL-5 to bind to it. Because these are antagonists. Antagonist basically means it's an antagonist of a receptor. Okay, so we have this monoclonal antibody can bind to this receptor, preventing IL-5 to bind to it, and that way there's no more inflammation. Kinetics degraded by proteolytic enzymes and widely distributed in the body. So most of these drugs, compared to omalizumab as well, they have an ability to kind of broken down after the effect is over. You probably are going to, I don't know, what's the half-life? It's a month, once a month injection.
Yeah.
Yeah. All right. So that's kind of like keeps it in the system in circulation for a while before we get that. So we are slowly going to be transitioning to all these biological monoclonal antibodies for migraine and for asthma and for those long-term treatments where we just have a 1 depot injection and we can prolong for a long period of time once we get the knack of what are the receptor.
All right, so getting to the clinical side, when are we going to use these? Eosinophilic phenotype. So when it says indication, they have allergic or eosinophilic, this is eosinophilic. Okay, these patients have to be 18 and over, so they have to be an actual adult, not an asthma adult. How is it administered? An IV infusion every 4 weeks. This goes back to that 1 month half-life that I talked about. Again, has to be injected or initiated in a healthcare setting, stored in the refrigerator. Black box warning for anaphylaxis. It also can show a transient increase in the CPK. Also can cause some oropharyngeal pain and myalgias, which sounds kind of weird for the oropharyngeal pain, it's an injection, but the myalgias can go through sense. Okay? As you see at the top in here, reslizumab injection, but this is an IV infusion. So are they probably ever going to give it at home? No. Yeah. Mepolizumab or Nucala, this is an IL-5 antagonist as well, for eosinophilic phenotype. These patients can be 6 years and older. So if you have a 14-year-old patient who needs to be started on biologic, would you prefer this one or Synthia? Nucala, because 6 and up versus 18 and up. This is a subcutaneous injection every 4 weeks, and the patient can also administer this one themselves. So this makes a lot more access to the care. Adverse side effects are much more minimal, not non-existent, just less. So we have headache, injection site reaction, and hypersensitivity reactions. A little bit more something we're all willing to probably deal with for this. Make sense? All right, the last one, I think.
Yeah. So this has like a more understood and investigated mechanism, benralizumab. So there are 2 things which is happening here. So we have your benralizumab, which is basically a monoclonal antibody. So that's kind of like the feature of most of those antibodies should look like this. On the right, we have an NK cell. On the left, we have an eosinophil. Okay, and this eosinophil has a receptor for IL-5. Right? For an eosinophil to be activated, it needs to have an IL-5 binding to this receptor. It primes the eosinophil, and that eosinophil it releases its content. Things to remember here: 2 mechanisms. Benralizumab, in the first way, it binds to IL-5 receptor in the eosinophil, prevents activation of IL. this particular eosinophil acid. So it comes and it binds over here. You can see that structure. That's the place where IL-5 should bind. So if it binds there, can IL-5 bind? It doesn't bind. If IL-5 cannot bind it, it doesn't activate this eosinophils to kind of do its function. On the other side, if you can see of this monoclonal antibody, it binds to a Fc fragment of an NK cell. What it's trying to really do is it's kind of trying to be a bridge between your NK cell and eosinophil to basically take this eosinophil back to your NK cell. If you can see here, this is what's really happening. And what is an NK cell? It's basically a cell responsible for causing apoptosis. So you take the eosinophil which is sitting there, you bring it back to a macrophage or an NK cell, take this and kill this eosinophil. We don't need this. This is over excess eosinophils in my body. So this antibody is kind of trying to take these eosinophils closer to your NK cell to cause apoptosis of this eosinophils. Got it? All right. So, and there's a lot of those scientific jargon out there. You don't really need to know all of it. I'm not going to test you. Please remember the target for right now. Okay. When you have benralizumab, you should be able to tell me it is mostly associated with your IL-5. Okay. It's not 4 and 30.
All right, hang tight with us. We're going to try to finish this section so we don't jump in the middle tomorrow. Okay, the benralizumab subcutaneous injection, so it's all in the logo. This is also for eosinophilic type, but this is 12 and older, so now we're looking at the asthma adults. Subcutaneous injection with a loading dose, and then a maintenance dose. That is all that you need to know right now. That's why I said, okay. Which of the following has a loading dose followed by a maintenance dose for syndrome. Okay? But every 4 weeks they're going to get 3 doses, so a month, and then they'll get those doses every 8 weeks instead. The patients can self-administer this when at home, but they still need to keep it in the refrigerator. Less side effects, so some antibody development, headache, fever, and pharyngitis, but otherwise pretty tolerable. Okay?
So this is probably the last of the sets of monoclonal antibodies, dupilumab. So it's IL-4 and IL-13. As you see, it's an antagonist of 4 and 13. So if we have an antibody which binds to these receptors, we cannot have 4 and 13 to bind. And what are we expecting? IL-4. What will not happen? IL-4 leads to IgE, antibody activation. IL-13 is mucus hypersecretion. So we're going to prevent those kind of functions if you're going to use this to kind of reduce or at least help the patients with asthmatic symptoms.
All right, Dupixent, dupilumab, eosinophilic phenotype, 6 years and older, subcutaneous with a loading dose and a maintenance dose. This is the same as the last one. However, this is weight-based dosing for pediatric patients, and then the regular loading dose plus maintenance every 2 weeks for adults. Okay, keep it in the refrigerator. Minimal side effects, antibody development, injection site reaction, and conjunctivitis. So remember, if you're holding on to the things that are different, this is the only one that has some sort of optic adverse side effect. Okay? This is an overview. We'll stop here and start tomorrow. Okay?